Welcome back. This is the first of two tutorials on mechanisms of hypoxemia. Tutorial 13. Hypoxic respiratory failure, Part 2. Mechanisms of hypoxemia, Part 1. Welcome back. Previously, we discussed the concept of anoxia, which is permanent damage to tissues caused by inadequate oxygen delivery, and how we as clinicians anticipate the problem of anoxia by identifying what we consider to be hypoxemia, which is inadequate oxygen levels within the blood to maintain homeostasis. So there is a particular point where we feel very jittery about the patient's oxygenation status, usually with a PaO2 of less than 60 millimeters of mercury or 8 kilopascals. We looked at the oxyhemoglobin dissociation curve and how it shifts from right to left, and how the S shape is critical to understanding how hemoglobin binds to oxygen and how pulse oximeters work. From that, we talked about why you need to do both blood gases and use pulse oximeters at the same time to make sure that they correlate. We then looked at how to quantify hypoxemia. The conventional approach that's been around for the longest time is to measure the alveolar to arterial oxygen gradient. The bigger that gradient, the more hypoxemic the patient. In recent decades, particularly in research or ARDS, an alternative approach that's simpler, known as the PF ratio, the PaO2-FiO2 ratio, has been used in millimeters of mercury, and the lower that number, the more hypoxemic the patient is, the critical number being 300. This time I will discuss airway closure, atelectasis, and lung abnormalities resulting in hypoxemia, and how to work those problems. Let's start with a clinical scenario. You're called to the medical assessment unit to see Trish, who's 59, who has a 4-day history of increasing shortness of breath. She's a cough productive of mucopurulent or green sputum and has rapid, shallow breathing. On her chest x-ray, there are bilateral infiltrates, and there's an example of a chest x-ray like this. And she's partially cyanosed, which means that her lips and her fingers are bluish coloured. A pulse oximeter is placed and the saturation is 84%. A blood gas is drawn and her PF ratio is 150. Why is Trish hypoxemic? Well, if you're going to look at hypoxemia, you really need to look at all the different components. And you can start off with the partial pressure of inspired oxygen, which really depends on the atmospheric pressure. Right now I'm at sea level, so the pressure is 760 millimeters of mercury, or 1 atmosphere, or 101 kilopascals. The higher you go up, the thinner the atmosphere is, the lower the pressure, the lower the inspired oxygen tension, because oxygen is always 21% of inspired gas. And that's why if you decide you're going to climb Everest, there comes a point where you will need supplemental oxygen just to stay alive. The single most important causes of hypoxemia, and the content of this tutorial looks at disorders at the alveolar pulmonary capillary interface. And these are ventilation perfusion mismatch, rolling all the way along to pure right to left shunt. But hypoxemia can also be caused by any reason why the oxygen content of blood is low. And remember that most of the oxygen in blood is carried by hemoglobin. So if the hemoglobin is low due to anemia or myeloproliferative disease or blood loss, well, the patient will be functionally hypoxemic. Also, the hemoglobin itself may be poisoned, particularly by carbon monoxide. And finally, the oxygenation of the blood and the hemoglobin may all be normal, but the cellular utilization of oxygen may be abnormal, for example, due to cyanide poisoning. Now, this is uncommon in this day and age, but can still occur with sodium nitroprusside infusions. The remainder of this tutorial, though, will deal with disorders of the alveolar pulmonary capillary interface. And the key thing you need to understand is that hypoxemia is principally caused by blood flowing through underventilated lung units. So where you have relatively high perfusion versus ventilation. Airway closure and atelectasis. This is a cartoon of blood flowing through a single alveolus. It's important to really understand that we're looking at the pulmonary circulation. And in the pulmonary circulation, the arteries contain deoxygenated blood and the veins contain oxygenated blood. Remember, the pulmonary artery comes from the right side of the heart and the pulmonary veins return to the left side of the heart. And so this can be really confusing because when we're looking at deoxygenated blood, we're talking about pulmonary arterial blood, and we're talking about oxygenated blood, we're talking about pulmonary venous blood. I'm going to just totally simplify this and just represent everything like this. On the incoming side of the circulation, the deoxygenated blood is mixed venous blood. So I'm going to refer to this as venous blood, and I'm going to talk about the partial pressure of venous blood going into the lungs, or the SVO2, the venous oxygen saturation, and the blood that goes out of the pulmonary veins into the left atrium. We're going to just refer to this as if it was systemic arterial blood, because functionally that's what it is. And we're going to talk about the PaO2 and the SaO2. So in subsequent tutorials and subsequent parts of this tutorial, that's what I'm going to talk about: mixed venous blood and systemic arterial blood. Now let's start with something that's really important. Gas always diffuses from where it is in high concentration to where it is in lower concentration. And this is particularly true of oxygen as it goes from the air into the mouth, into the larynx, down the trachea, through the tracheobronchial tree, into the alveoli, and subsequently from the alveoli, a gas-filled space, into the blood, a liquid-filled space. There must be a concentration gradient for this to happen. And so when you look at oxygen flow in the major airways, we have a PO2, a partial pressure of oxygen of 115 millimeters of mercury, or 19 kilopascals. That's at the mouth, for example. And down at the alveoli, the oxygen tension is 110 millimeters of mercury, or 14.5 kilopascals. The venous blood has a much lower oxygen tension. It's 40 millimeters of mercury, or 5 kilopascals. So there is a big gradient when that capillary meets the alveolus for oxygen to flow into the capillary, and it keeps on doing that. And so what we have here is this oxygen gradient. Now, what happens is when oxygen moves from the alveolus into the blood, it's replenished from the major airways. So remember, when the P-alveolar O2 starts to fall from oxygen moving into the blood, there's now a bigger gradient between the alveolus and the major airways, so oxygen rushes down from the major airways. And this goes all the way through the major airways up to the mouth. So oxygen is being continuously replenished from dead space gas, from physiologic dead space gas, into the alveoli. And it's important to understand this because gas exchange occurs throughout the respiratory cycle. In any given minute, you're only inspiring for maybe 10 seconds, you're expiring for 50 seconds, but gas exchange is going on all the time. So there's lots of gas exchange going on during expiration. And if you go down to the pulmonary capillaries, there is no pulsatile blood flow. Blood just runs in a continuous conveyor belt through those lung units as if nothing else is happening. The speed may increase when their heart rate goes up, but otherwise it's like a conveyor belt of oxygen coming out of the alveoli and going into the capillaries and being replenished from above by oxygen from the dead space. Alveolar oxygen refreshes due to diffusion from the upper airways. Never forget this. An essential concept to understand in respiratory physiology is airway closure. As we age, the elasticity of our lungs and chest wall changes such that the conducting airways are not always patent. They may dynamically close during expiration. As a consequence, if the airways are closed, then there is no longer that column of oxygen running from the mouth to the alveoli. There are a variety of clinical situations, as we will see later in this tutorial, where airway patency is lost, such as disease process in the lumen, such as secretions in the wall, such as edema or bronchospasm, or outside the wall, such as pneumothorax, pleural effusions, or medley other diseases. In these situations, the airways become dynamically compressed during expiration, or else they're continuously compressed. This is an example of one such event where we have airway closure. And it doesn't matter whether this is physiological with aging or pathological due to airways disease, it happens. And it's a major cause of phasic hypoxemia, meaning patients who become hypoxemic during expiration. So in this situation here, we have our continued gradient. Remember, there's going to be a gradient of alveolar oxygen to venous blood oxygen, even with relatively low alveolar oxygen tensions, because venous oxygen is only 40 millimeters of mercury. So what's happened here is we have airway closure during expiration, but gas is continuously taken up from the alveoli into the bloodstream. The problem is it cannot be replenished from above, so the gas becomes progressively more stale. So the alveolar O2 content as expiration goes on becomes lower and lower and lower and closer to the venous oxygen content. And so eventually this gas becomes very, very stale during expiration. Eventually, if the airways don't reopen during inspiration, or airway opening is only partial, eventually these alveoli become completely unstable and they collapse. And this is a process known as atelectasis. And most of the time when we see atelectasis on chest x-ray, for example, it's been caused by airway closure. The normal physiologic response to atelectasis is hypoxic pulmonary vasoconstriction. When there is no oxygen coming from these lung units, the blood flow shuts off. And this happens all the time. It even happens to you. You may have been sitting there bored listening to this and started yawning. Why do you yawn? You yawn to recruit back open collapsed alveoli from when you are hypoventilating. And so this is a normal thing, but it happens more as you get older, and it happens very, very commonly, almost universally, with acute pulmonary disease. Let's review the impact of atelectasis in pulmonary disease. Remember, when you don't have lung disease and you have atelectasis, blood flow is shut off, so you don't go all cyanosed because blood just redistributes to well ventilated and well perfused lung units. But in some situations, for example, with pneumonia or systemic sepsis, there is widespread generation of vasodilatory metabolites that prevent hypoxic pulmonary vasoconstriction happening. It also happens during anesthesia. Remember, virtually all anesthesia drugs are vasodilators, so they interfere with hypoxic pulmonary vasoconstriction. Now on this cartoon here we have two lung units. Both of them are very well perfused and very well ventilated, and we have our oxyhemoglobin dissociation curve. And you can see here that on the arterial side we have blood that reaches up to nearly 100% saturated, and here on the venous side we have blood that's 70% saturated. In this situation here now we have a lung unit that collapses. We have atelectasis, but blood flow continues through that lung unit. So there's no oxygen being taken up by this lung unit. And as a consequence, we have venous blood going back into the arterial side of the circulation. This is known as venous admixture. And what it does is it dilutes down well-oxygenated blood with poorly oxygenated blood. And as a consequence, in this cartoon, you can see that the saturation has fallen to 84%. When you look at where this puts the patient on the oxyhemoglobin dissociation curve, it's here, 84%, translating into a PaO2 of 60 millimeters of mercury or 8 kilopascals. And this is the negative impact of right to left intrapulmonary shunt on oxygenation, and it is hugely problematic. Now let's move on to talk about the different types of atelectasis that you may encounter in your clinical practice. The first type of atelectasis Our first cause of atelectasis is something I've already mentioned, and it's compression of the airways. And there are all kinds of different ways this can happen. The airways may be compressed externally due to alterations in chest wall mechanics, for example, during anesthesia or during laparoscopic surgery. It can happen due to chest trauma, particularly when there are bandages wrapped around the chest. It can happen due to an expansion of the pleural space, for example, pneumothorax or hemothorax or hydrothorax. Or it can occur due to mediastinal masses such as large lymphomas, a thyroid mass, thymic masses, etc. And finally, it can occur due to intra-abdominal processes that expand the abdominal cavity. That happens in laparoscopic surgery, obviously, but it can happen due to all kinds of diseases that result in intra-abdominal hypertension, such as inflamed bowel, ascites, or medley other diseases commonly seen with fluid overload in trauma. It can happen due to overexpanded lung tissue, such as in autopeep, where gas is trapped in the alveoli at end expiration. It can happen due to heavy lung tissue, and that is where there's pulmonary edema, where the lungs may be very soggy, for example, due to heart failure or due to non-cardiogenic pulmonary edema, such as we see in ARDS or septic shock. And finally, it can happen due to heavy lung tissue associated with lung consolidation. The second form of atelectasis is obstructive atelectasis. That happens where the airways proximal to the alveoli become obstructed due to something either within the lumen or within the wall. Most commonly it's caused by mucus plugs. Large chunks of mucus just plug off airways. Gas within the alveoli is gradually reabsorbed, and you have this reabsorptive atelectasis, but it's principally caused by airway obstruction. And the way we kind of look at this is the obstruction is either in the lumen, which is mucus plugs, or blood clots, or inhaled foreign objects like a tooth or a peanut, or God forbid, a surgical swab, or something that's in the lumen, for example, bronchospasm or bronchial edema, or a lung tumor, or lung metastasis, or various other forms of space-occupying lesions within the lung. So that's obstructive atelectasis. The third form of atelectasis requires a little bit more explanation, and this is known as absorptive atelectasis, and this is much more common than you may imagine. Remember that the alveoli are air-filled spaces, and they only stay inflated because they contain air. 79% of that is slowly diffusing nitrogen. In many ways, nitrogen acts as a buttress that holds alveoli open. Now, there are times, such as during induction of anesthesia, when very, very high concentrations of oxygen are delivered. Sometimes this also occurs when a bedside healthcare provider places a non-rebreather face mask on a patient and gives uncontrolled high concentration oxygen to the patient. So in this situation, the patient is getting 100% oxygen through a face mask, for example. Now that translates into a partial pressure of inspired oxygen of 713 millimeters of mercury, 94 kilopascals. This drives up the alveolar oxygen concentration up to roughly 670 millimeters of mercury, or 88 kilopascals. Now, I mentioned to you earlier on that there was already a fairly decent gradient between the alveoli and the pulmonary venous blood. And normally that's about 70 millimeters of mercury. But in this situation now, we have a 600 millimeters of mercury difference in the partial pressure of oxygen within the alveoli and the venous blood. And of course, the bigger the concentration gradient, the more rapidly that oxygen flows out of the alveoli into the blood. And as a consequence of this, the PM arterial O2 goes up to maybe 600 millimeters of mercury, or up to 80 kilopascals within normal lungs. But something not so good happens here, because as a result of all this oxygen flowing out of the alveoli, these alveoli become quite unstable, because remember, the nitrogen has been washed out. And of course, once the nitrogen is washed out, there's nothing much holding the alveoli open, and the alveoli will continue to empty with this very high concentration of oxygen until a very large proportion of them collapse. And this is what happens with hyperoxia. We get this process known as absorptive Atelectasis. And it happens very, very commonly during induction of anesthesia. Now, it can be easily resolved by the application of a recruitment maneuver. This is, 25, 30, 35 centimeters of water of pressure applied for, with normal lungs, maybe 10 seconds. It'll gradually reverse if you just put a patient on a ventilator and give them some PEEP, but it's something that you need to be aware of. And it's also something you really need to be aware of at the end of anesthesia if you give a patient 100% oxygen, because once the patient has been extubated, you can't give them a recruitment maneuver or give them a lot of PEEP unless you put a face mask on their face and close down the APL valve. And so this is what happens with absorption atelectasis. And normally it's not really a huge problem in terms of oxygenation because of hypoxic pulmonary vasoconstriction, but it is a problem if somebody is in an ambulance and they're getting a lot of oxygen and it's uncontrolled because they'll get widespread absorptive atelectasis, and at some point they will hit a tipping point where they'll start to run out of oxygen. Let's move on to lung abnormalities that result in hypoxemia. When confronted with a patient who has hypoxemia, it's worthwhile having a system for working the problem. This is an anatomical approach where you start with the airway and you work your way down to the alveoli. The airway starts at the mouth or the nose, goes to the tongue, larynx, trachea, bronchi, and then all the different divisions of bronchi all the way down to the alveoli. And material that occlude the airway, either in the lumen in the wall or outside the wall, can cause hypoxemia. Beyond the airway, there is the lung interstitium. This is part of lung parenchyma, but it is not the space between the alveoli and the pulmonary capillaries. This is the other side of the alveoli, and the interstitium can become diseased and cause problems with gas exchange. Then beyond the lung parenchyma itself are extrapulmonary structures in the mediastinum, in the pleura, and the abdominal cavity that may cause problems with gas exchange, principally due to compression. And finally, it's possible that blood will just move from one part of the heart to the other without ever going through the lungs. It shunts from right to left and can cause hypoxemia. An easy way to remember the system is what I call the 6S approach to hypoxemia. Start off with the airways. And the airways may be obstructed with snotty material or slimy material. So this is blood or mucus in particular or other secretions, and this is astonishingly common in clinical medicine where there are tons of secretions just blocking up the airways. It's particularly a problem of patients who can't cough. The second area is the interstitium, and this is also very common where the interstitium becomes soggy from water. That water may come directly from the bloodstream from a hydrostatic process because the pressure within the pulmonary capillaries is really high, or else it may leak out as a form of interstitial fracking associated with increased capillary permeability, as is seen in sepsis or other forms of inflammation. The lungs may be stiff because the interstitium becomes fibrotic and the alveolar capillary interface may become fibrotic, and there's a range of diseases that cause this. And then the alveoli may become sticky as a consequence of the presence of an inflammatory exudate. Outside of the lung parenchyma itself, then, we have our extrapulmonary causes, and in this case I use the term squished for external compression. And finally, vascular disease is shunty, where there's a right to left intracardiac shunt. So we have snotty or slimy, soggy, stiff, sticky, squished, and shunty. Snotty or slimy refers to where you get all kinds of stuff accumulating within the airways. And because the airways are partially obstructed but not necessarily closed or collapsed, the gas turnover time, that's the time constant, is longer. So even if you have the same gradient for oxygen between the mouth and the alveoli, maybe even increased, because of all the stuff in the airway, it's really slow for gas to turn over. And as a consequence of this, you get stale gas in the alveoli and dead space and venous admixture. This is a really common cause of hypoxemia. The second cause is within the interstitium, and I call this soggy lung. And soggy lung refers to water collecting in the space outside the blood vessels and outside the alveoli. So the interstitial space gets soggy and fluid collects there. And this can happen with cardiogenic pulmonary edema associated with diastolic heart failure or non-cardiogenic pulmonary edema, an example of which would be ARDS. There is increased lung weight, and as a result of this, there is a significant amount of compression atelectasis, but there's also redistribution of blood flow within the lungs, and this is a major cause of hypoxic respiratory failure in clinical medicine, where patients may either become fluid overloaded because they have acute kidney injury, or they have heart failure, or they've been given too much IV fluid, or else they have capillary leak syndrome. An extreme version of this results in the collection of fluid in the pleural spaces, known as pleural effusions, and indeed within the alveoli. When the pressure within the pulmonary capillaries gets so high, the alveoli start to flood with water. Where material collects in the interstitium, the lungs become stiff, and this happens with widespread pulmonary fibrosis. It occurs acutely with ARDS, and it can occur at a very, very early stage with ARDS. It's also seen chronically with fibrosing alveolitis, extrinsic allergic alveolitis, sarcoidosis, and various other chronic lung diseases. Oxygen diffusion is impaired due to solid material in the interstitium, and it gets between the alveolus and the capillary. Although the alveoli may be patent and well oxygenated, there is a significant increase in the alveolar to arterial oxygen gradient. Sticky lung units. This refers to the collection of material within the alveoli. This typically happens when there is bacterial infection of air spaces, and this causes an inflammatory reaction, and the result is the accumulation of an inflammatory exudate within the alveoli. There is significant impairment of the alveolar capillary interface. There is also a problem with expansion of the alveoli because these alveoli are stuck down. There may also be interstitial edema and indeed alveolar edema, and this results in widespread atelectasis. Now, if we go back and we visit Trish, remember Trish, the patient at the beginning of this tutorial? Well, Trish has bronchopneumonia, and this is likely caused by bacterial infection caused by Haemophilus or pneumococcus or various other bacteria. Her problem is a combination of slimy and sticky airways, and the treatment for this is antibiotics. There's also an argument, for example, for using steroids. She needs lots of physical therapy of her chest. She needs to move those secretions out, and if necessary, she'll need oxygen. Squished refers to external compression of lung units. And we mentioned this when we talked about atelectasis. Airway compression prolongs the alveolar refresh time and results in stale air within the alveoli. And it's either in or outside the wall, and this is caused by all kinds of stuff, but you will see people coming into the hospital with lung tumors that cause significant airway compression, or thyroid or mediastinal masses, but you can also see with bronchospasm, bronchial edema, autopeep, or all kinds of stuff associated with pleural disease or abdominal compartment syndrome. So this is squished, and it doesn't necessarily mean that there's actually anything wrong with the lungs themselves. The lung parenchyma may be normal, the tracheobronchial tree may be normal, but there's something else causing compression of lung tissue, causing hypoxemia. And it's important to understand this because you don't want to be treating someone, for example, for pneumonia because their CRP is high and they're hypoxemic when they actually have a problem due to external compression of lung tissue. Finally, S also stands for Shunty, and in this situation, there is nothing wrong with the lungs. The problem is an intracardiac shunt due to a ventricular septal defect or patent foramen ovale or various congenital heart diseases. And you should always suspect this when the chest x-ray is completely clear and the patient is hypoxic. And there are a variety of different tests that can be done, for example, a bubble study using an echocardiogram. In this situation, it's essential to consider various alternatives and to consult a cardiologist. Let's review this tutorial. This tutorial was the first of two on mechanisms of hypoxemia, and I started with a discussion on airway closure. I then went on to talk about atelectasis and lung abnormalities resulting in hypoxemia. Finally, I discussed how you can work the problem of the hypoxemic patient to figure out what's going on. And next time I will discuss shunt and ventilation perfusion mismatch as part of ventilation perfusion relationships. And when I've done that, we'll get into an introductory discussion about oxygen therapy. We'll see you then, and I guarantee you'll learn something. So that was mechanisms of hypoxemia part 1. Next time we'll move on to the second part, which is ventilation perfusion mismatch, shunt, and introduction to oxygen therapy. If you're enjoying these tutorials, don't forget to subscribe, leave some comments and likes below, and visit me at ccmtutorials.org.